a moment to introduce our first speaker. It's Ehsan Saadat. He's a board-certified spine surgeon. He specializes and has a specific interest in disc replacement and motion preservation, but also does minimally invasive microscopic surgery and decompressive surgery of the cervical and lumbar spine. He also does minimally invasive spinal fusions and also does do complex revision surgery. As I mentioned, we all like to focus on a variety of the spine surgery, and he certainly is capable and skilled at that. He's prolific and active as a researcher and author. He's published numerous articles in spine surgery, and he treats patients from throughout the region and outside the region. And so I'd like to welcome Ehsan come talk to us tonight, and I hope you'll give him a warm welcome. Thank you.
Hi, everyone. It's a pleasure to be here. Thank you for that very nice introduction. Let me see if I can close that. We were just talking earlier. I think neither of us has used a PC in the past 2 decades, so this is a little bit of a kind of a game to find out where this goes. I honestly, I think the last time I used a PC was probably 15, 20 years ago. So my task tonight is to talk about surgical management of symptomatic cervical myelopathy and radiculopathy. This is a very big topic, and what I'm going to try to do is to talk a little bit initially about what is cervical radiculopathy, how is it different than cervical myelopathy, what are some of the conservative treatment options for cervical radiculopathy, and when is it appropriate to do conservative treatment for myelopathy. And then the bulk of this will be hopefully an interesting talk with a lot of cases that demonstrates the way we think about how to approach these problems surgically once somebody has either failed conservative management or in situations where conservative management is not appropriate. So I think it's nice to start with some definitions first. I like to think about cervical radiculopathy as an unhappy nerve root, which is a peripheral nervous system problem. This usually involves 1 or 2 nerve roots, usually on one side, right? So most people present with pain going down one arm in 1 or 2 nerve root distributions. And there's occasionally paresthesias involved as well as weakness in that arm. These patients typically don't have the long track signs, hyperreflexia, discoordination, things that go along with a central nervous system problem like cervical myelopathy. Cervical myelopathy is an unhappy spinal cord, which is a central nervous system problem, right? And these patients, they can have numbness and tingling, they can have weakness, but it's really a problem of discoordination. They will frequently say, I keep dropping things, my handwriting has gone worse, I can't text as well as I used to, I can't button my buttons as well as I used to, my walking balance has become bad, right? And some people even go as far as saying, I have family members who tell me I walk like a drunk person, even though I'm not drunk, and I don't know why this is. So when we hear problems like that or complaints like that, we start to automatically think about, is there a cervical spinal cord problem that's leading to this discoordination, this, funny, difficult to define thing? And it is very often that we actually see a mixed picture of myelopathy and radiculopathy, right? So somebody can have pressure on the spinal cord and on a nerve root, right? And they can have a mixed picture. And so that's really where, doing a detailed history, doing a detailed examination, and then having a very detailed look at the MRI is going to then guide what we're going to do. One of the things I always talk with patients about is the spine is like a puzzle. There's very rarely, and I think everybody who's sitting here can agree to this, there's very rarely when we can see 2 patients that are exactly the same, either in terms of their presentation or in terms of their pathology or in terms of what we end up doing for them. There are definitely themes that they fall into, but they're very, very rarely do we ever see 2 patients that are identical to one another in terms of their pathology and their presentation. And one thing that I always keep in mind is that similar symptoms can be caused by very different pathologies. And that's why, as spine surgeons, we're always very, very kind of focused on finding the lesion and making sure that the imaging that the patient has actually correlates with their symptoms. In other words, we tend to not treat the MRI as much as we treat the patient, right? And so we use the MRI as a way of kind of confirming what our diagnosis is based on what the patient is telling us and based on what we see on the physical examination. So this is a nice case to kind of start off this discussion with, and I hope you can see the pictures well up here. This is a gentleman, 40 years old, engineer, healthy, very active, who comes in basically with pain that's going down the left arm, very, very severe, and it started kind of on an acute basis after he lifted something. I don't remember him having any significant weakness. He definitely did not have any hyperreflexia or any discoordination signs or symptoms that would point to a myelopathy. And this is an MRI, and you can see on the left side, this is a one cut off of the midline on sagittal images, where you can see a very large disc herniation at C67. And on the right side, on the actual pictures, you can see a left-sided disc herniation at C67 that's pretty significantly compressing that exiting nerve root. There's maybe a little bit of an indentation on the spinal cord, but there's no signal change, and the canal in general is pretty patent. So this is a patient who has a clear, classic cervical radiculopathy. This is another one. This is a 40-year-old woman who came in with a kind of a mixed picture. So she was having some hand discoordination, dropping things, maybe a little bit of gait imbalance, nothing super obvious, but she would say, you know, when I go dancing, I feel like I'm losing my balance all the time. And also she was having some left-sided radicular arm pain in addition to those kinds of symptoms. And on this MRI, you can see this is a young person's MRI, right, with very little disc degeneration, very little kind of spondylotic changes. And here at C5, C6, we can see that there's a central disc bulge that's causing some deformation of the spinal cord and some stenosis in the central canal. I didn't put up all the axial images just to kind of keep this moving along. Another case I'll present, and then we'll kind of talk about what I did for each one of these and why we did them. This is a much older patient. This gentleman is 72 years old, and his presentation is very classic myelopathic symptoms. You know, hand numbness, dropping things, hand weakness, discoordination, significant walking imbalance. And he came into the office, and I said, "What brings you here?" And he said, "I can't walk." And I said, "Why?" And he said, "When I walk, I lose my balance. And I used to be able to go for 2-mile walks every day, and now I have to have my wife with me because otherwise I'm going to, you know, sway to one side or fall, or, you know, something bad's going to happen to me." And here you can see this is a old person's spine with a lot of spondylotic changes, a lot of disc degeneration, and pretty significant compression on the spinal cord at C3-4 and to a slightly lesser extent at C4-5. I'm going to show 2 more cases, and then we'll talk about what the options are. So this is another one. This is a 70-year-old gentleman who also presented with pretty significant myelopathic symptoms that also were very similar to the last patient I just talked about, right? So significant hand numbness, discoordination, and really, really bad walking imbalance. And this is a very athletic gentleman who basically had stopped playing soccer because he couldn't walk or run anymore without losing his balance and falling. And on this MRI, you can see a congenitally stenotic canal, right? So if this central canal in the cervical spine is a little bit tighter than what we are typically used to seeing. And what you can appreciate is multi-level spinal cord compression, especially at C3, C4, where the canal is very, very tight. There's clear deformation of the spinal cord and some signal change in the spinal cord. So unfortunately, I don't have a pointer that points to here, but what we call gliotic changes. These are basically a sign of a spinal cord injury that's ongoing. So this is one case, and then this is probably the most extreme one of these cases. This is a 56-year-old gentleman, IV drug user, homeless, who comes in with significant and progressively worsening neck pain and significant and progressively worsening myelopathy. Hand numbness, again, hand weakness, significant difficulty walking with balance issues. And on this MRI, we can see that he has a kind of a chronic infection in the anterior cervical spine on the bottom. There's an abscess that's forming in the front of the spine. And as a result of that infection, he has significant bony destructive changes in the lower cervical spine and a kyphotic deformity that's formed. And because of that, he's now getting spinal cord compression, and the spinal cord is kind of draped over that kyphotic deformity in his neck, which is a situation where that makes the spinal cord unhappy. Spinal cord does not like to be draped over a kyphotic deformity, right? So if you compare this, for example, to this MRI, we can see this person has a very lordotic cervical spine, right? Which is this is the position that the spinal cord is happy in, minus the disc herniation that's in there, as opposed to this one where there's a kyphotic deformity and the cord is draped over that deformity. So 4 different cases, kind of progressively worsening in the degree of severity, both in symptoms and in the radiographic findings. And the question becomes, what do we do for these things, right? So these are all patients who, now, one thing I neglected to mention earlier is for cervical radiculopathy, which is a peripheral nervous system problem, conservative treatment, non-operative treatment is often the appropriate first step in treating those patients, right? Especially if they don't have any significant weakness, if they don't have any significant numbness, and it's just a pain issue. As long as the pain is able to be managed with anti-inflammatory medications, steroids, injections, physical therapy, those are appropriate measures in treating these patients. And once those fail, that's when we start to think about surgical options. In cervical myelopathy, especially in somebody who has progressively worsening myelopathy, the answer actually is surgical. And we have very, very good literature in the spine surgery literature going back probably 50 to 60 years, where we know that myelopathic patients tend to worsen over time, right? The decline is not going to be most of the time acute, so they'll have long periods of time where they're symptomatically stable, but they will, if you follow these patients without doing anything for them over years, what they'll say is, last year my walking was a little bit better, my hand coordination was a little bit better, now I'm a little bit worse, and I don't know what happened. And then you watch them a little bit more, and then 6 months later, a year later, they may say, I've kind of my function has dipped a little bit more. So because of that reason, for somebody who's myelopathic, we typically tend to recommend surgery. And then the question becomes, what do you do surgically, right? How do you treat these pathologies surgically? And like I said, these are 4 different scenarios, and they really need different kind of a customized plan for each one of them. That's different one to the other. So what are the surgical options for patients with cervical stenosis? There are anterior options, and the most traditional one of them being an anterior cervical discectomy and fusion, which is a tried and true operation that's been around for a long time. The newer alternative to an ACDF is an artificial disc replacement, which is what Dr. Decky was alluding to earlier, which is a motion preserving option. Some of the advantages of an ADR, or an artificial disc replacement, is basically maintaining the motion in the spinal motion segment that then we think decreases the likelihood of adjacent segment degeneration of the disc above and below that segment, to essentially having to work overtime and then breaking down earlier than they otherwise would have. The other anterior option is a corpectomy. So in certain cases where the problem is not just at the disc level, but also behind the vertebral body, then sometimes you actually have to remove the entire vertebral body to be able to fix that problem. And I'll show you an example of this later on, or a hybrid construct that involves either a fusion and a disc replacement, or a corpectomy and an ACDF combined, depending on what the exact anatomy is and what the pathology is. Then there's posterior options, which is laminectomy only, which is, it's a similar operation to what we would do in the lumbar spine. A laminectomy and fusion, where we do a decompression of the spinal cord and then stabilize that with placing screws and rods. Or a laminoplasty, which we'll talk about later as an alternative to a laminectomy and fusion, which is one of my favorite operations. And so there's anterior options, there's posterior options, and there's combined anterior and posterior options in terms of treating pathology. And this occasionally becomes necessary in people who have many, many levels of problems that all need to be addressed, especially with the fusion, which I'll show you an example of later on. So how do we decide? Do we go anteriorly? Do we go posteriorly? Do we do both? Do we do a fusion? Do we do a disc replacement? There's so many options. How do we actually decide these things? The way I think about them is, number one, where is the pathology, right? Is there a disc herniation from the front of the spinal cord that's pushing on the spinal cord, right? In that case, it's much, much easier for me to do an anterior operation rather than a posterior operation. Is the pathology, how many pathological levels are there? Is there a disc herniation at one level, or is the spinal cord compressed at 5 levels? And that makes a difference in terms of what we do, because certain techniques become much more favorable in a situation where there's more than 3 levels of stenosis, more than 3 levels of cord compression. And then the other thing I ask myself is there a deformity or is there not a deformity, right? So is there, like I showed earlier, a kyphotic deformity of the spine that needs to be corrected, or is the spine generally the way we want it to be with 1 or 2 disc herniations or nerve compression that needs to be addressed? And then the other kind of general category to think about is, are we going to be able to preserve motion in this patient, or do we need to actually fuse the spine? And part of that has to do with age, right? So for a younger patient, we're much more keen to try to find a motion preserving operation as opposed to a fusion operation. Part of this has to do with alignment, right? So for somebody who has a kyphotic deformity of their spine, a motion preserving operation is probably not appropriate. And then there's other factors that come into play. For example, if the patient smokes. So we have very, very good literature in our spinal literature to say that in smokers, the rates of success with fusion operations is less, right? The rates of a non-union is higher. And so if I can find a motion preserving operation that does not rely on a fusion in somebody who smokes, that's what I'm more apt to choose. So going back to the question of where is the pathology, this is a case I showed earlier in that 40-year-old gentleman with left-sided cervical radiculopathy, and now I have arrows pointing to where the pathology is, right? So there's a large disc herniation on the front that's towards the left, compressing that nerve root. And so this, and then this is his preoperative x-ray. So this is a gentleman who actually had a previous C5, C6 fusion operation several years ago, and this disc herniation is at the level below that fusion operation. So for this, I chose an anterior approach. And anterior approaches like an ACDF or a disc replacement or a corpectomy, these are very, very good approaches for direct access to anterior spinal pathology. So for somebody that has a disc herniation or some other pathology pushing on the front of the spinal cord. And anterior approaches, especially ACDFs and corpectomies, allow us to correct cervical alignment much, much better than a posterior only operation. So we tried to do this. Yes, there we go. So this is actually an intraoperative video of the surgery I performed on that patient whose case I just showed you. To the left is cephalad, to the right is caudad. This view is a surgeon's view, right? So you're looking directly down at the spine. These metallic objects are the pins that distract the vertebrae from each other, so we can access the disc in the middle. And I have an arrow pointing to where the herniated disc is, and the spinal cord is directly ventral to that. So you can see in this approach, which is an anterior approach, we have direct access to the front of the spinal cord, and we have direct access to that disc herniation, which is the thing that just came out. And what you're looking at is a surgeon's viewpoint. So this is actually, you're standing in my shoes, looking down at the spine, taking out that disc. So, and this is what a cervical disc replacement looks like. So you can see that C6-7 disc on the right image, which is collapsed, right? And where the MRI showed the disc herniation. And on the left side, we can see the disc replacement that actually reestablished the normal disc height, right? And the good thing about this is that this actually allows motion, right? So I did not have to worry about, I need a little bit more time, sorry. And I didn't have to worry about, making sure this fusion heals because we're not asking for a fusion to heal, right? We'll go through the rest of this quickly. So this is another patient. This is a 74-year-old lady who has a calcified mass that's sitting on the lamina of C5, I believe, compressing the spinal cord posteriorly. And this goes back to the question of where's the pathology. This would be very difficult to take out from an anterior approach because there's a big important structure, the spinal cord sitting in front of you, which you can't really move away. The other question is how many pathologic levels are there, right? So if there's 1 or 2 levels of pathology, then an anterior operation is a very easy, elegant, nice thing to do for that patient because the recovery from an anterior operation is actually very quick and very easy. If there's more than 2 or 3 levels of pathology, then I tend to start thinking about, can I do something posteriorly for this? The reason for that being a multi-level operation from the front can carry a risk of a higher incidence of dysphagia and other kind of approach-related complications that we don't typically see with a posterior approach. So the anterior options being an ACDF, which is an anterior cervical discectomy and fusion. This eliminates motion. It can correct alignment or instability. And the downside of this is the risk of future adjacent segment disease, where, as we talked about, if you eliminate motion in 1 or 2 segments, the other ones have to kind of work overtime so they can actually break down earlier than they otherwise would, causing problems. An ADR, or an artificial disc replacement, preserves motion. It reduces the risk of adjacent segment disease. Now, I think at this point we have enough literature in our literature to prove that. But it's not suitable in a situation where there's significant instability or if there's significant malalignment, for example, kyphosis. And a corpectomy is good for what we call retrovertebral disease or complex deformity cases. So this is that 74-year-old gentleman who I showed with myelopathy, and he has 2 levels of spinal cord compression anteriorly and a little bit of cervical kyphosis, really not much. So for this, I chose a 2-level ACDF, which is an anterior operation. This very nicely reconstituted his kind of normal cervical alignment, took the pressure off his spinal cord, and very quickly, actually, his myelopathic symptoms went away. And this is a 1-year postoperative image showing a healed fusion, and he was very, very clinically very happy. This is that 40-some-year-old lady who I showed earlier with a 1-level disc herniation with kind of a mixed myeloradiculopathy picture. And for this one, I chose to do a disc replacement, which is very nice because you can see that this actually completely preserves her preoperative motion at the surgical level. Now, what about if there's pathology at 3 or more levels? As we talked about, there's a little bit of an increased risk of dysphagia with 3 or more levels of anterior surgery, and especially if the pathology is higher in the cervical spine, so C2, C3, or C3, C4, and in older patients. So, and with more than 2 or 3 levels of anterior cervical fusion, there's a higher risk of a non-union or the fusion not healing, regardless of whether or not the patient smokes. So when there's more than 2 levels of pathology, I tend to think about, is there something I can do posteriorly that's going to accomplish my goal, right? And is going to be easier on the patient and safer on the patient. So this is where a laminoplasty comes into play. And a laminoplasty is a motion preserving operation that enlarges the spinal canal, but maintains the motion. So it's a really, really good alternative for somebody who's myelopathic that has more than 3 levels of spinal cord compression. And this is an example of, this is the same patient who I showed earlier with multi-level spinal cord compression and the significant C3-4 stenosis and core signal change. And this is a postoperative MRI of that same patient showing how much more open the central canal is now. That little bit of white that you see in the spinal cord is the residual gliotic change in the spinal cord that was there before, and which may never go away. And this is the postoperative images demonstrating the excellent range of motion that this patient maintained after surgery. And then the question becomes, what if you have a mess like this? So what if there's significant kyphosis, there's bony destruction here, and this is something that actually needs a really big operation. So this actually required a 3-level anterior cervical corpectomy. So we removed 3 of the vertebrae altogether, reconstructed it with an allograft piece of bone, but that construct then needs posterior stabilization, because that if I just did this from the front, that's by no means stable enough to allow it to heal. So I'll wrap up here, and I apologize for running over. The message again is the spine is kind of like a puzzle. There's no 2 patients that are exactly the same. Similar symptoms can be caused by very different pathologies, and each case is unique. And when it comes to these kinds of problems, each patient really needs an individualized treatment plan that suits their pathology and suits their general health status and kind of what is going on and what we're trying to treat. So 4 different cases, 4 different answers, and I think this really nicely demonstrates the range of options that we have in treating cervical stenosis.